A child with a history of asthma presents to the Picu with severe respiratory distress. Describe the immediate interventions you would implement to stabilize the patient's airway and improve oxygenation.
In a situation where a child with a history of asthma presents to the Pediatric Intensive Care Unit, Picu, with severe respiratory distress, my immediate focus would be on stabilizing the airway and ensuring adequate oxygenation. I would first assess the patient's airway, breathing, and circulation, ABCs, to determine the severity of the respiratory distress. My initial priority would be to administer oxygen therapy. Depending on the child's level of distress, I might use a high-flow nasal cannula, a non-rebreather mask, or if necessary, proceed to non-invasive positive pressure ventilation, e.g., CPAP or BiPAP, to increase oxygen delivery and reduce work of breathing. Simultaneously, I would prepare for further interventions by obtaining vital signs and conducting a rapid clinical assessment, paying close attention to signs of hypoxia, such as altered mental status, cyanosis, or the use of accessory muscles for breathing. I would immediately administer short-acting bronchodilators, such as albuterol, via a nebulizer or metered-dose inhaler with a spacer, in conjunction with anticholinergics like ipratropium to relieve bronchospasm. Steroids would also be initiated promptly to reduce inflammation, which is a key component of asthma exacerbation. If the child's condition did not improve with these interventions, I would work closely with the multidisciplinary team, including respiratory therapists and physicians, to consider escalation to more invasive support, such as mechanical ventilation. Throughout this process, I would continually monitor the child's oxygen saturation, respiratory effort, and overall response to treatment, ensuring that any necessary adjustments to the management plan are made quickly. Effective communication with the family is also essential during this time. I would provide them with updates on the child's condition and explain the steps being taken to stabilize and improve their breathing. By acting swiftly and in collaboration with the healthcare team, the goal would be to reverse the acute respiratory distress and prevent further complications.
A young patient with a suspected infection is showing signs of sepsis. Outline the rapid assessment and treatment plan you would initiate.
When a young patient presents with signs of sepsis, a rapid and systematic approach is crucial to prevent the progression to septic shock. My first step would be a thorough assessment of the patient's airway, breathing, and circulation, ABCs, to ensure they are stable, while also looking for key indicators of sepsis, such as fever, hypotension, tachycardia, tachypnea, and altered mental status. Time-sensitive interventions are critical in sepsis management. Within the first few minutes, I would ensure that intravenous, access is obtained promptly, preferably with 2 large-bore 4 lines, to facilitate fluid resuscitation and medication administration. Given that sepsis often leads to hypoperfusion, would immediately start administering a bolus of 4 fluids, typically 20 ml per kilogram of isotonic saline or lactated Ringer's solution, while continuously monitoring the patient's hemodynamic status, including heart rate, blood pressure, and urine output. Simultaneously, I would collect blood cultures and any other necessary cultures, e.g., urine, wound, or sputum, before starting broad-spectrum antibiotics. The goal is to initiate antibiotic therapy within the first hour of recognizing sepsis, as early administration is associated with improved outcomes. Once cultures are obtained, I would administer antibiotics that target likely pathogens, considering the patient's age, medical history, and potential infection sources. Monitoring the patient closely, I would assess for signs of shock or organ dysfunction, such as poor capillary refill, decreasing urine output, or altered level of consciousness. If the patient's blood pressure remained low despite fluid resuscitation, I would escalate care by preparing for the administration of vasopressors, such as norepinephrine, under physician direction. Throughout this process, I would ensure ongoing communication with the multidisciplinary team to coordinate further diagnostics, such as blood tests for lactate levels, coagulation studies, and imaging to identify the source of infection. I would also keep the family informed about the patient's condition and the critical steps being taken. By rapidly initiating these interventions, the goal would be to stabilize the patient, limit the progression of sepsis, and reduce the risk of long-term complications.
A child experiences a cardiac arrest in the Picu. Explain the steps involved in cardiopulmonary resuscitation, CPR, and the management of post-cardiac arrest care.
When a child experiences cardiac arrest in the Pediatric Intensive Care Unit, Picu, rapid and effective cardiopulmonary resuscitation, CPR, is critical to optimize the chances of survival. Upon recognizing the arrest, I would immediately activate the emergency response team and begin basic life support by initiating chest compressions while assessing the patient's airway and breathing. For high-quality CPR, I would ensure chest compressions are initiated immediately, with a compression depth of at least 1/3 of the chest diameter and a rate of 100 to 120 compressions per minute. I would prioritize minimizing interruptions in compressions to maintain adequate perfusion to vital organs. Simultaneously, I would ensure appropriate ventilation, delivering breaths using a bag valve mask with a ratio of 30 compressions to 2 breaths if alone, or 15 compressions to 2 breaths if another rescuer is present. If an advanced airway, such as an endotracheal tube, is in place, compressions would be continuous, with breaths provided every 2 to 3 seconds. Next, I would apply a defibrillator as soon as possible to determine the cardiac rhythm. If the child is in a shockable rhythm, such as ventricular fibrillation, VF, or pulseless ventricular tachycardia, VT, I would deliver a defibrillation shock according to Pediatric Advanced Life Support, PALS, guidelines, and immediately resume CPR for 2 minutes before reassessing the rhythm. If the rhythm is non-shockable, such as asystole or pulseless electrical activity, PEA, I would continue CPR and administer medications, such as epinephrine, every 3 to 5 minutes, while maintaining chest compressions and ventilations. Throughout the resuscitation process, I would work closely with the healthcare team, ensuring ongoing communication and coordination. We would continuously monitor the patient's oxygen saturation, end-tidal CO2, and heart rhythm. Any reversible causes of cardiac arrest, the H's and T's, hypoxia, hypovolemia, hyperkalemia, tension pneumothorax, toxins, etc., would be addressed during this time. Once return of spontaneous circulation, ROSC, is achieved, immediate post-cardiac arrest care is critical to prevent secondary damage and improve long-term outcomes. I would ensure that the patient remains on mechanical ventilation if needed, optimizing oxygenation and ventilation while avoiding hyperoxia. Fluid resuscitation or vasopressors would be continued as needed to maintain adequate blood pressure and organ perfusion. The patient would be closely monitored for signs of cardiac or neurological instability, and blood gases, electrolytes, and lactate levels would be assessed to guide further management. In this post-arrest phase, would also work with the multidisciplinary team to develop a comprehensive care plan, including neuroprotective strategies such as targeted temperature management, if appropriate, and continuous EEG monitoring to detect seizures. Communication with the family is essential during this time, providing them with updates on the child's condition and the efforts being made to stabilize their health. Through prompt, coordinated action and vigilant post-cardiac arrest care, the aim is to minimize complications and promote the best possible recovery for the child.
A child with a traumatic brain injury is admitted to the Picu. Describe the neurological assessments and monitoring techniques you would use to evaluate the patient's condition.
When a child with a traumatic brain injury, TBI, is admitted to the Pediatric Intensive Care Unit, Picu, thorough and ongoing neurological assessment is crucial for monitoring the patient's condition and detecting any signs of deterioration. My first step would be to perform a comprehensive neurological examination, beginning with an evaluation of the child's level of consciousness using the Glasgow Coma Scale, GCS, modified for pediatric patients. This scale assesses eye-opening, verbal response, and motor response, providing an objective measure of the child's neurological status. A declining GCS score could indicate worsening intracranial pressure, ICP, or brain injury, necessitating immediate intervention. I would also evaluate pupil size, symmetry, and reactivity to light, as these can provide critical information about brainstem function and potential herniation. Any abnormal findings, such as unequal or non-reactive pupils, would be flagged as a medical emergency. Additionally, I would assess the child's motor strength and movement, checking for asymmetry, posturing, or abnormal reflexes, all of which could signal focal neurological deficits or increased ICP. Vital signs, particularly blood pressure, heart rate, and respiratory patterns, would be closely monitored. Changes in these parameters, such as bradycardia, hypertension, and irregular breathing, Cushing's triad, could indicate increased ICP and impending brain herniation. Maintaining cerebral perfusion is vital, so I would ensure that the patient's blood pressure is adequately supported to prevent further ischemic damage to the brain. For more continuous monitoring, an intracranial pressure, ICP, monitor may be placed by the neurosurgical team if indicated. ICP monitoring provides real-time data on pressure within the skull, and I would use this information to guide interventions aimed at reducing elevated ICP. Normal ICP values for children typically range from 5 to 15 mm of mercury, and any values exceeding 20 mm of mercury would be cause for concern, requiring immediate measures such as sedation, osmotic therapy, e.g., mannitol or hypertonic saline, or elevation of the head of the bed to 30 degrees to enhance venous drainage. In some cases, cerebral perfusion pressure, CPP, monitoring may also be used, as it reflects the balance between systemic blood pressure and ICP, ensuring that the brain is receiving adequate blood flow. Regular assessment of serum electrolytes and blood gases would be necessary to monitor for imbalances such as hypernatremia or hypocapnia, which can affect ICP. Throughout the child's stay in the Picu, I would conduct frequent neurological assessments, re-evaluating the GCS, pupil response, and motor function at regular intervals to detect any early signs of deterioration. Additionally, I would collaborate with the broader healthcare team to determine the need for imaging studies, such as CT scans or MRIs, to assess for changes in the injury or development of secondary complications like cerebral edema or hemorrhage. Lastly, I would maintain open communication with the family, updating them regularly on the child's condition and explaining the significance of the neurological assessments and monitoring techniques being used. My goal would be to detect any changes in the child's neurological status as early as possible, allowing for timely intervention and better long-term outcomes.
A patient with hemodynamic instability requires continuous monitoring. Discuss the types of hemodynamic monitoring devices you would use and the parameters you would assess.
For a patient with hemodynamic instability, continuous and vigilant monitoring is critical to ensure timely interventions and improve outcomes. Depending on the severity of the instability, I would employ both non-invasive and invasive hemodynamic monitoring devices to obtain a comprehensive assessment of the patient's cardiovascular status. Initially, I would start with non-invasive devices such as a cardiac monitor to continuously observe heart rate and rhythm, and a non-invasive blood pressure, an IBP, cuff to regularly check blood pressure. Additionally, I would use pulse oximetry to measure oxygen saturation, SpO2, which is crucial for determining whether adequate oxygen is being delivered to tissues. These basic tools provide essential information about the patient's condition but might not be sufficient if the instability progresses. If the patient's condition deteriorates or fails to stabilize, invasive monitoring would become necessary to gather more precise data. One of the most common invasive monitoring tools is the arterial line, or ART line. This device, inserted into an artery, typically the radial or femoral, provides continuous, real-time blood pressure monitoring, offering much greater accuracy than non-invasive methods, especially in patients with rapidly changing blood pressures. An arterial line also allows for frequent arterial blood gas, ABG, sampling, which helps assess the patient's oxygenation, ventilation, and acid-base status. In situations where more detailed information about the patient's fluid status and heart function is required, a central venous catheter, CVC, might be inserted into a large vein, such as the internal jugular or subclavian vein. This device enables the measurement of central venous pressure, CVP, which reflects the amount of blood returning to the heart and provides insight into the patient's preload and overall fluid status. Elevated CVP levels could indicate fluid overload or heart failure, while lower levels might suggest hypovolemia, guiding fluid resuscitation or diuretic therapy based on the patient's needs. For more complex cases, particularly where the patient's heart function is significantly compromised, a pulmonary artery catheter, often referred to as a Swan-Ganz catheter, might be used. This advanced device measures pulmonary artery pressure, PAP, cardiac output, CO, and mixed venous oxygen saturation, SVO2, offering a comprehensive view of both right and left heart function. Additionally, the catheter allows for the calculation of systemic vascular resistance, SVR, which indicates the resistance the heart encounters when pumping blood. This information is vital in determining whether the patient requires vasopressors to increase blood pressure or vasodilators to reduce resistance and improve blood flow. Throughout this monitoring process, I would keep a close eye on several key hemodynamic parameters. Monitoring heart rate and rhythm is essential, as arrhythmias or an abnormally fast heart rate can signal poor perfusion or a deteriorating cardiac condition. Blood pressure, particularly mean arterial pressure, MAP, is another critical factor to assess, as adequate MAP is necessary to maintain organ perfusion, with the goal typically being above 65 mm of mercury, though specific targets might vary depending on the patient's age and condition. Central venous pressure provides valuable information about venous return and right heart function, while cardiac output and cardiac index, which adjusts for body surface area, give a detailed picture of the heart's pumping capacity. Lastly, systemic vascular resistance guides the use of medications to either increase or decrease the resistance the heart encounters during contraction. As I gather and interpret these hemodynamic measurements, I would collaborate closely with the healthcare team to ensure that interventions are tailored to the patient's evolving condition. Treatment might involve fluid resuscitation to improve preload, vasopressors to raise blood pressure, or inotropes to enhance cardiac output. Each intervention would be guided by the data obtained from the monitoring devices, ensuring that treatment is both effective and appropriate. In addition to medical management, maintaining open communication with the family is crucial. I would explain the purpose of the various monitoring devices in clear, understandable terms, helping them to grasp the necessity of such intensive monitoring and the steps being taken to stabilize their loved one. By continuously evaluating hemodynamic parameters and working closely with both the healthcare team and the family, my goal would be to maintain the patient's stability and prevent any further complications.
A child is on mechanical ventilation. Explain the key parameters you would monitor and the interventions you would implement to optimize ventilator settings.
When a child is on mechanical ventilation, careful monitoring of key parameters and timely interventions are essential to ensure effective ventilation and prevent complications. My primary focus would be on monitoring respiratory and hemodynamic parameters, as well as closely assessing the child's overall clinical condition to optimize the ventilator settings and support respiratory function. The first parameter I would monitor is oxygenation, which can be assessed by tracking oxygen saturation, SpO2, using pulse oximetry and arterial blood gases, ABGs, to check the partial pressure of oxygen, PAO2. Ensuring that oxygenation is adequate while avoiding hyperoxia is crucial. If the child's oxygen levels are too low, I might adjust the fraction of inspired oxygen, VO2, which is the concentration of oxygen delivered by the ventilator. The goal would be to maintain an SpO2 between 92 to 97% and PAO2 within an appropriate range, reducing VO2 gradually to avoid oxygen toxicity. Another critical parameter is ventilation, which refers to the effective removal of carbon dioxide, CO2, from the body. This can be monitored by measuring end-tidal CO2, EtCO2, and PaCO2 from ABGs. If CO2 levels are high, indicating hypoventilation, I might adjust the tidal volume, VT, the amount of air delivered with each breath, or increase the respiratory rate, RR, to enhance ventilation and lower PaCO2. In pediatric patients, the tidal volume is usually set between 6 to 8 ml/kg of ideal body weight, with adjustments made based on the patient's lung mechanics and gas exchange needs. Airway pressures are another important aspect to monitor, particularly peak inspiratory pressure, PIP, and plateau pressure, PLAT. PIP reflects the maximum pressure reached during inspiration, and if it's too high, it could lead to barotrauma or lung injury. Plateau pressure, measured during a pause in ventilation, provides information about lung compliance. The goal is to keep plateau pressures below 30 cmH2O to minimize the risk of lung injury. If pressures are elevated, I would evaluate whether the child's lungs are stiff or if there is an issue with the ventilator settings. Adjustments might include reducing the tidal volume, increasing the inspiratory time, or improving patient ventilator synchrony through sedation if necessary. To optimize lung recruitment and prevent atelectasis, would also carefully monitor and adjust the positive end expiratory pressure, PEEP, setting. PEEP helps maintain alveolar stability by preventing their collapse at the end of expiration. The PEEP level would be tailored to the child's specific condition, balancing the need to improve oxygenation while avoiding excessive pressure that could impede venous return or cause lung injury. Throughout the process, I would monitor the child for signs of respiratory distress, such as the use of accessory muscles, tachypnea, or desaturation, which may indicate inadequate ventilatory support or poor lung compliance. Chest auscultation would be performed regularly to check for abnormalities like wheezing, crackles, or diminished breath sounds, which could suggest issues such as mucus plugging, pneumothorax, or atelectasis. Hemodynamic stability is another key aspect to consider when a child is on mechanical ventilation. Positive pressure ventilation can affect cardiac output and venous return, so I would closely monitor blood pressure, heart rate, and urine output to detect any signs of compromised circulation. If hemodynamic instability occurs, I might need to adjust PEEP levels or consider fluid resuscitation or vasopressor support. In collaboration with the respiratory therapist and physician, I would frequently evaluate the overall clinical picture, including the patient's ABG results, chest X-rays, and lung mechanics, to determine whether further adjustments to the ventilator settings are needed. We would also assess whether the child is ready for weaning by monitoring trends in spontaneous respiratory effort, gas exchange, and ventilatory support requirements. Communication with the family would be essential, as I would explain the purpose of mechanical ventilation and keep them informed about the child's progress and any changes to the care plan. By carefully monitoring these parameters and making thoughtful adjustments, the goal would be to optimize respiratory support while minimizing the risk of complications and facilitating recovery.
A child requires multiple medications, including intravenous, and enteral routes. Describe the safety precautions and calculations you would use to ensure accurate medication administration.
Administering multiple medications to a child, particularly through both intravenous, and enteral routes, requires meticulous attention to detail to ensure safety and accuracy. In pediatric care, the risk of medication errors is higher due to factors like varying drug dosages based on weight and the need for precise calculations. My approach would focus on safety precautions, accurate calculations, and close monitoring throughout the medication administration process. The first step in ensuring accurate medication administration is to thoroughly review the child's medical orders and medication profile, confirming the correct medication, dosage, route, and timing for each. I would pay special attention to the child's weight, as pediatric medication dosages are typically calculated based on weight, mg/kg or mcg/kg. To prevent any errors, I would double-check the child's weight and use a reliable weight-based dosing chart or calculator for each drug. For 4 medications, precise dosing and rate of administration are critical. I would first ensure that the 4 site is patent and functioning correctly. I would calculate the correct dose using the ordered amount of drug per kilogram, confirming the total volume required and the appropriate rate of infusion. For example, if a drug is ordered as 10 mg per kilogram for a child weighing 15 kg, the total dose would be 150 mg. If the concentration of the drug is 50 mg per milliliter, I would calculate that the child needs 3 milliliters of the medication. To avoid errors, I would use the 6 rights of medication administration: right patient, right drug, right dose, right route, right time, and right documentation. I would also be vigilant about the compatibility of 4 medications, especially when multiple medications are being administered through the same 4 line. Certain drugs can precipitate or become ineffective if mixed with incompatible solutions, so I would consult a compatibility chart or hospital protocol to verify whether medications can be given together or if the line needs to be flushed between medications. For enteral medications, I would ensure that the correct formulation, liquid, crushed tablet, etc., is being used and that it is safe to administer via a feeding tube if necessary. Some medications are not safe to crush or dissolve, so I would double-check with pharmacy guidelines for each medication. I would verify the dosing using the appropriate weight-based calculation, similar to 4 medications. For example, if a drug is ordered as 5 mg per kilogram and the child weighs 20 kg, I would calculate that 100 mg should be given. If the enteral suspension has a concentration of 10 mg per milliliter, the child would need 10 milliliters of the suspension. To avoid administration errors, I would be mindful of timing and spacing between medications, especially if there are drugs with potential interactions. Medications that affect gastric pH, such as antacids, might interfere with the absorption of other enteral medications, so I would ensure proper timing to prevent interactions. To further ensure accuracy, I would use an independent double-check system, where a second nurse verifies the medication calculations, dosage, and route before administration, particularly for high-risk medications like opioids, anticoagulants, or insulin. This is especially important for 4 infusions that require precise dosing and titration. Infusion pumps would be used for 4 medications that require continuous or intermittent administration to ensure a controlled and accurate rate of delivery. I would program the pump with the correct infusion rate based on the prescribed dose and double-check the settings before starting the infusion. For instance, if the child requires a medication to be infused at 0.1 mg per kilogram per hour, I would calculate the rate according to the child's weight and the drug's concentration, ensuring the pump is set accurately. After administration, I would closely monitor the child for any signs of adverse reactions or side effects, especially for medications that require monitoring of blood levels, such as antibiotics, anticonvulsants, or diuretics. Periodic assessments of vital signs, laboratory values, and clinical status would guide any necessary adjustments to the medication regimen. Lastly, clear communication with the family is essential to ensure they understand the medications being given, their purposes, and any potential side effects to watch for. By taking these safety precautions and following strict calculation protocols, the goal would be to administer medications accurately and safely, reducing the risk of errors and promoting the child's recovery.
A child with chronic pain is receiving palliative care. Discuss the different pain management strategies you would consider and the importance of assessing pain levels.
In managing a child with chronic pain receiving palliative care, the primary goal is to alleviate suffering, enhance comfort, and improve the child's quality of life. Pain management in palliative care requires a comprehensive and individualized approach, considering both pharmacological and non-pharmacological strategies. It is also crucial to assess pain levels regularly to adjust treatment plans effectively. The first step is pain assessment, which is critical to understand the child's experience and to tailor interventions accordingly. In children, assessing pain can be challenging, especially in those who may not be able to communicate effectively. I would use age-appropriate pain scales, such as the FLAC scale, for infants and younger children, the Wong-Baker-Faces scale, for older children, or a numerical rating scale, for those who can verbalize their pain. I would also observe nonverbal cues, such as facial expressions, body posture, or changes in behavior, as these can be indicators of pain in children who are nonverbal or have difficulty expressing their discomfort. Pharmacological pain management would be central to controlling chronic pain. I would follow the World Health Organization, WHO, analgesic ladder, which suggests a stepwise approach, starting with non-opioid analgesics for mild pain and progressing to opioids for more severe pain. For mild to moderate pain, medications like acetaminophen or nonsteroidal anti-inflammatory drugs, NSAIDs, e.g., ibuprofen, would be considered. These can be effective in reducing pain and inflammation and are often well tolerated in children. For moderate to severe pain, opioids such as morphine or hydromorphone might be necessary. These medications provide more potent pain relief but require careful dosing and monitoring for side effects, such as respiratory depression, constipation, and sedation. I would ensure the use of appropriate opioid dosages based on the child's weight and regularly reassess the pain to make necessary dose adjustments. If the child's pain is not well controlled with standard doses of opioids, I might consider opioid rotation, where a different opioid is substituted to improve efficacy and reduce side effects. Additionally, adjuvant medications such as gabapentin or amitriptyline could be added to manage neuropathic pain, which is often challenging to treat with opioids alone. Muscle relaxants like baclofen may also be used if the child has associated muscle spasms contributing to pain. Alongside pharmacological approaches, non-pharmacological strategies play a significant role in palliative care and are often highly effective in managing chronic pain. These can include physical therapies, such as gentle massage, warm or cold compresses, or physical therapy exercises, which can help alleviate musculoskeletal pain and improve mobility. I would also consider psychological and emotional support, as chronic pain can have significant emotional and mental health effects on a child. Techniques such as distraction therapy, guided imagery, and relaxation exercises can be useful in helping children cope with pain. Art therapy or music therapy may also provide comfort, helping children express feelings of pain and anxiety through creative outlets. In cases where conventional pain management strategies are insufficient, advanced pain management techniques might be considered. For instance, nerve blocks or epidural analgesia could be used to provide more localized pain relief, particularly for children with pain that is difficult to manage systemically. In extreme cases, palliative sedation may be used to relieve intractable pain and suffering when other measures have failed, though this is typically a last resort. Regularly reassessing the child's pain is vital to ensure that the chosen pain management strategies are effective. Pain levels can fluctuate due to disease progression, treatment changes, or new sources of discomfort. I would reassess pain frequently, adjusting medications or interventions based on the child's feedback, clinical condition, and any side effects that emerge. Family involvement is crucial in this process. I would maintain open communication with the family, educating them about pain management strategies and listening to their concerns. Families often know their child's behavior and pain signals better than anyone, and their input is essential in ensuring effective pain management. Additionally, I would provide emotional support to the family, acknowledging the challenges of caring for a child with chronic pain. By employing a holistic approach that includes both pharmacological and non-pharmacological strategies, and by regularly assessing pain levels, I would aim to manage the child's pain effectively, ensuring their comfort and dignity in palliative care.
The parents of a critically ill child are experiencing emotional distress. Describe the strategies you would use to provide emotional support and facilitate communication with the family.
Supporting parents of a critically ill child, who are often overwhelmed with emotional distress, requires empathy, active listening, and clear communication. My approach would focus on providing both emotional support and practical guidance to help them navigate their child's condition and care. The first and most important step is to establish trust and rapport with the family. I would take the time to introduce myself and explain my role in their child's care, making it clear that I am there to support both the child and the family. I would invite them to share their concerns, fears, and expectations openly, ensuring that they feel heard and understood. By actively listening and acknowledging their emotions, would create a safe space for them to express their feelings, which can be a significant source of comfort in such a stressful time. To address their emotional distress, would offer empathy and reassurance. This involves recognizing the gravity of their situation and validating their emotions, whether they are feelings of fear, helplessness, or anger. For example, I might say, "I can see how difficult this is for you, and it's completely understandable to feel overwhelmed. We are here to support both you and your child through this." Simple, heartfelt acknowledgement of their distress can help them feel less isolated in their experience. Facilitating clear and compassionate communication is also vital, especially given the complex and often overwhelming nature of medical information in the pediatric intensive care setting. I would provide regular updates on their child's condition in a manner that is clear and free from medical jargon. Explaining the treatment plan, procedures, and any changes in a way that is easily understandable helps parents feel more in control and less anxious. If they have any questions or uncertainties, I would encourage them to ask and take the time to explain things thoroughly, ensuring they feel informed and involved in decision-making. Repeating and summarizing key points can help them retain important information during times of stress. In addition to keeping them informed, I would also assess the family's preferred communication style. Some parents might want detailed, frequent updates, while others may find it too overwhelming. Respecting their preferences in terms of how much and how often they wish to receive information can help reduce anxiety. I would also involve them in the care process as much as they are comfortable with, encouraging them to participate in decisions about their child's care, which fosters a sense of control during a challenging time. Providing emotional resources can be another way to support families. I would offer referrals to support services such as counseling, social workers, or hospital chaplains. These professionals can help parents process their emotions, work through feelings of grief or fear, and develop coping strategies. Additionally, peer support groups or parent-to-parent programs, where they can speak with others who have gone through similar experiences, can be invaluable in reducing feelings of isolation and providing hope. Recognizing that the emotional well-being of the parents directly affects their ability to care for their child, I would also gently encourage self-care. This might involve reminding them to take breaks, get rest, or eat regularly, even though these may seem insignificant in the context of their child's critical illness. Offering practical assistance, such as finding quiet spaces within the hospital or coordinating short breaks for them to step away from the bedside, can make a significant difference in reducing burnout and emotional exhaustion. Lastly, it's important to be culturally sensitive in my approach. Families may come from diverse backgrounds, and their ways of coping, communicating, and understanding illness may vary. I would be mindful of their cultural or religious practices, ensuring that any communication or support I offer is respectful and aligned with their values. If needed, I would coordinate with hospital resources like interpreters or cultural liaison services to ensure that there are no barriers to effective communication or care. In conclusion, by combining empathy, clear communication, and access to emotional and practical support resources, my goal would be to reduce the emotional burden on the parents, helping them feel supported and informed during an incredibly challenging time. This holistic approach would help build trust, foster collaboration, and improve their ability to cope with the stress of having a critically ill child.
Discuss a challenging ethical scenario you have encountered in pediatric critical care. How did you approach the situation and resolve the ethical conflict?
In pediatric critical care, ethical dilemmas often arise when balancing the child's best interests with family beliefs, medical recommendations, and overall prognosis. One challenging scenario I faced involved a critically ill child with a terminal condition. The healthcare team recommended transitioning to palliative care after exhausting all treatment options, but the parents insisted on continuing aggressive treatment despite the very low chance of survival. The child had a severe neurodegenerative disorder and multiple organ system failures. The medical team determined that further aggressive interventions, such as mechanical ventilation and dialysis, would only prolong suffering without improving the child's quality of life. Transitioning to palliative care, aimed at providing comfort and dignity during the child's final days, was deemed the most compassionate approach. However, the parents, deeply distraught, held on to hope for a miracle and requested that life-sustaining interventions continue. This created an ethical conflict between respecting the parents' wishes and fulfilling the healthcare team's obligation to minimize suffering and avoid futile interventions. To navigate this conflict, I relied on principles of ethical decision-making, including respect for autonomy, beneficence, non-maleficence, and justice. Honoring the parents' role in decision-making was crucial, but so was considering the child's best interests and avoiding harm. Firstly, I facilitated ongoing, empathetic discussions between the healthcare team and the parents. It was important to acknowledge the parents' emotions and fears while explaining the medical reality. Using clear, non-technical language, we discussed the limited benefits and significant burdens of continued aggressive treatment versus the advantages of palliative care, such as pain relief and comfort. We also convened a meeting with the hospital's ethics committee, which included a diverse group of professionals, physicians, nurses, social workers, and spiritual care providers. This multidisciplinary team offered varied perspectives and expertise, emphasizing that continuing invasive treatments without realistic benefits conflicted with the principle of do no harm. Understanding the deep emotional and cultural components influencing the parents' decisions was essential. Their religious beliefs played a significant role in their desire for continued treatment. To address this, we involved a hospital chaplain, who provided spiritual support, helping the family reconcile their faith with the medical reality. This step was crucial in addressing the emotional and spiritual aspects of the conflict, allowing the parents to feel supported and heard. We also adopted a shared decision-making model, recognizing that the parents needed time to process the information and come to terms with the prognosis. We agreed to continue certain supportive treatments for a short, predetermined period while prioritizing comfort measures. This approach allowed the family to feel they were not abandoning hope too quickly. During this time, we provided regular updates on the child's condition, which helped the parents gradually understand the futility of aggressive interventions. Eventually, through continued discussions, the parents agreed to transition to palliative care. They expressed gratitude for the compassionate approach, which respected their beliefs while advocating for the child's comfort. Palliative care was initiated, focusing on pain management, emotional support, and creating a peaceful environment for the child's final days. This experience highlighted the importance of empathy, patience, and collaboration in navigating complex ethical challenges in pediatric critical care. Balancing medical expertise with sensitivity to the family's emotional and spiritual needs was key to guiding them toward a decision that honored the child's dignity while respecting the parent's role in decision-making.